Thank you, Hurt. Thank you, Peter. I realize I'm the last person standing between you and lunch, so I'll be quick. And I hope you'll find this case both educational and a little bit entertaining. I call this a window to the heart, which you'll understand in a moment. So this is a 73-year-old gentleman who had a long history of Barrett's esophagus. He'd been under surveillance according to proper protocol, which is actually not very usual. Most of the time they're not followed according to protocol, as we know. On his most recent surveillance endoscopy, a biopsy showed an intramucosal adenocarcinoma, and he was referred to our center at the Mayo Clinic in Florida for consideration of endoscopic therapy. At his first endoscopy, we found a normal duodenum and stomach. He had a long segment of Barrett's esophagus with some nodularity at the uppermost extent of the squamocolumnar junction, and there appeared to be some extension just under the squamous epithelium at the margin of the squamocolumnar junction. So we mark this. We use a technology called volumetric laser endomicroscopy as a supplement to our endoscopic imaging. And we, in fact, observed what we thought was some subsquamous. The squamous epithelium is denoted by this layered epithelium here, whereas the Barrett's esophagus here loses its epithelium layer. And we saw these abnormal glands underneath squamous epithelium. So this further suggested that the patient had some slight 1 to 2 millimeters of Barrett's dysplasia underneath the squamous epithelium. This will become important as you see here. So the patient was in a clinical trial using a new band EMR device. This was the first views, and I apologize, I did not have my high definition video recorder this day. You can see the proximal cautery mark, and it's well above the observed squamocolumnar junction because of the reasons we spoke about. So we're beginning our EMR more proximal than we would normally. And you can see we have some initial problems with the suction. There appears to be some puckering in the area of greatest interest. We're getting the surrounding mucosa, but not the area of greatest interest. To be honest, the fellow was doing the procedure at this time. I was directly observing the fellow, and he was having some difficulty getting adequate positioning of this device and suctioning the area that we were most interested in resecting. So at about this point, I took over the procedure myself, and we attempted to suction in this area just below the cautery mark. Everything seemed to be going, apart from the fact that it was a little bit difficult to suction the desired epithelium in, the procedure was going relatively smoothly. You might recognize that this is a little bit of a different band ligating device than most of us have used. This is the Captivator EMR device from Boston Scientific, and it was part of the initial clinical trial registry with this device that was led by Dr. Jacques Bergman. So eventually we were able to suction in the area that we were interested in just below the cautery dot, and we deployed the band, and everything was fairly uneventful. I'll skip ahead just a little bit now for the sake of getting you to lunch on time. And we'll continue. The procedure at this point is proceeding normally. We snare the tissue, and we always snare below the band if we can reasonably get a grasp of the snare below the band. We do not pre-inject, as most people who perform Barrett's EMR that I've worked with also do not perform pre-injection. So we immediately suction the tissue into the endoscope. We always try to grasp the tissue immediately so that it doesn't pass into the stomach, where sometimes it can cause some delays. And the first thing we do when we remove the tissue is we inspect it beside the patient, and we look for the target sign. And as you'll see briefly here, there's a triple target sign. There's not just a muscularis propria. Sorry, it went by very quickly here. There's not just a muscularis propria, but there's a muscularis propria, some adventitia, and some fat. So we were very nervous at this point that we'd had a deep perforation. That's mediastinal fat that you can see. Quite a worrisome looking endoscopic resection. So at this point, we reintubated the patient. This is unedited video, as you can see. So we reintubate the patient. The first thing I did was actually pass to the stomach and resuction the contents of the stomach. We do all of our procedures under carbon dioxide, so I did not need to do any change in the carbon dioxide. But we went past the lesion, and notice here, you could see that very briefly. I'll just back that up 1 second. We didn't want to look very long, but you see a structure that's beating, and you see a white material on the surface of that structure, which is the pericardium right there. So that's the posterior left atrium. We're looking at the pericardium, and so the first thing we do, well, honestly, the first thing we do, I'll tell you, my wife is a yoga instructor, so she's taught me to remain calm at all times. So the first thing we do is we practice some abdominal breathing exercises ourselves. And now we look at the pericardium again, and we see that we have a very wide perforation. And you can imagine we're going through our head, how are we going to close this perforation? Our options are TTS clips, over-the-scope clip devices. As we're pulling back, again, we see that there's both a normal resection to the submucosa, and then there's this deep perforation looking directly at the pericardium. So we thought about OTC, OTSC, but my concern using OTSC was that we had very little space between the esophageal wall and the pericardium, and I was quite worried, even with the twin grasper, that we would entrap pericardium in the posterior left atrial wall. So we decided to use the zipper method with the TTS, and I'll skip ahead. So first of all, why did this happen? Could it be prevented? I've had 3 esophageal perforations in my career of doing this for about 15 years and about 500 procedures. The first 2 occurred in a clearly abnormal esophagus. One was a scleroderma patient. Another was an achalasia with a dilated esophagus. This was the first perforation I've had in an otherwise normal Barrett's esophagus without underlying motility disorder or scleroderma. So in retrospect, I'm not sure if this could have been prevented. I'm going to skip a little bit of the didactic portion here just for the sake of time because we've seen a lot of this, and I'm just going to show how we manage this particular case. So we decided to use the TTS clip closure method, the so-called zipper method, and the important principles of closing perforations, particularly large perforations. And you can see we've already started at the distal end of this. So we start outside of the primary defect and place clips sequentially very close together. We stack these on top of each other, and you can see that it's challenging because this is a very wide defect. Trying to grasp and close that defect was technically very challenging to do. It eventually required 13 clips in this defect that was approximately 1.5 to 2 centimeters. So the principle here is to start outside the defect, to slowly pinch it together like a zipper. You can see the layers here, the submucosal layer, and then the muscle layer here, and the pericardium still beating there. But we're stacking the clips very close together so that we get a secure closure. With a lot of these longer procedures, I try not to think so much of the very end game as to try to get the next clip placed perfectly. It's quite important to avoid misplacing a clip because one misplaced clip, particularly at the beginning of the procedure, can make it very difficult to place subsequent clips. You really want a linear, sequential passing, and you can see how many clips we placed distal to the actual perforation because we're trying to pinch that closed. So again, I'll skip ahead a little bit here. Fortunately, we were able to eventually extend that closure up to the very proximal end here. We still have a little bit of a gaping hole. This took about an hour to fully close. And we just continue with multiple clips here. And you use as many clips as you need to stack. One other method that some have tried is to then use an endo loop, a detachable loop. and then put the endo loop around these clips and pinch them all together. And you can actually see this one here is quite difficult. This one we actually did misdeploy on one side of the lesion, and I was quite worried that we would not then be able to get secure closure, but fortunately the next clip we did get just above that. But it's quite important, and you can see we're using the cap to suction a little bit and also using the cap to push the other clips a little bit to the side. It can be a little bit difficult here. Watch the top end of that clip. That's going to slip off repeatedly, and we keep closing, making sure that we have it, but it did slip away. But fortunately, the next clip above it did hold. So again, just extending on towards the end of the clip closure, we eventually get above the perforation, and then we do one or two more clips, and you can see that misdeployed clip here with a little gap in between, and that's where it becomes technically very difficult to fill that gap. But again, we were able to get one additional clip in between there, and eventually you can see that here. We're trying to get that gap in between the proximal most clip here, which is misdeployed on the upper lip, and the next clip downstream. So that's why it's so important to stack these clips very close together. Again, I'll just skip ahead to the end, and we eventually get the clips all the way up now, fully closing the defect, and we're up into the normal squamous epithelium here. So we have one other problem here, which is we've resected a lesion above our target lesion. We intentionally started above the most worrisome area, and yet we had to abort the procedure at this point. There was no way to continue the endoscopic resection. So not only did I have to repair the defect, but I had to tell the patient we had actually not resected the intended target of the procedure. So it was a difficult situation. And again, just to show the sort of final closure here, getting those last clips up at the top here. We'll continue on in the case. So the next procedure that I typically do, so typical for me is the 3 cases I've had in my career, but this is how I've managed all 3. I try to get negative pressure within the esophagus by passing a nasogastric tube. I cut off the end of the nasogastric tube so I can put a guide wire down and then deliver the nasogastric tube over a guide wire. The alternative would be to drag it down endoscopically, but we don't place the nasogastric tube in the normal blind fashion for fear that it would actually puncture through our newly closed site. The additional thing that I do is I cut extra side holes in the esophageal portion of the nasogastric tube. So we actually take scissors and we cut small side holes in the mid portion of the nasogastric tube, so we have negative pressure not only in the stomach but also in the esophagus, so that even swallowed saliva we're aspirating, and we leave the patient to intermittent wall suction for several days. I usually don't get a CT scan right away. We know there's going to be some air in the mediastinum. More importantly is to give them prophylactic antibiotics and follow them for signs of mediastinitis. So we talked about the TTS clip with the zipper closure, and other locations an OTS clip would have certainly been appropriate. Covered stents I don't like to use here because of the outward pressure likely will not allow the epithelium to reclose together. I think suturing would also have been consideration here, but again I was concerned I couldn't place the suturing Apollo device without puncturing into the left atrium. So again, I'll just skip some of the didactic portion, some of the other methods here, and we actually saw this slide earlier. So back to our case. The patient fortunately did well. We put his NG tube to low intermittent wall suction. We treated him with IV fluids, antibiotics. He actually had a little candidal esophagitis, which I didn't show you, so we gave him some fluconazole as well. And we followed with serial chest x-rays and KUBs. We consulted cardiothoracic surgery in our inpatient gastroenterology team. Fortunately, he did well, but then the pathology result came back, and it showed some specialized Barrett's mucosa with focal atypia indefinite for dysplasia. Remember, the prior biopsy had intramucosal adenocarcinoma. We did actually at that point request the outside biopsy for re-review, and they confirmed an area suspicious for adenocarcinoma. So we had the discussion with the patient and the family that our plan was either to offer him esophagectomy at this point or to bring him back. He was a very elderly gentleman. He did not want an esophagectomy. So he said, we'll wait 3 months, let this heal, and we'll bring him back. So 3 months later, we brought him back. We actually did an EUS at that point, just to further stage that we didn't have any lymph node involvement. We had a small benign appearing lymph node, and we went ahead and did a second mucosal resection. And this is what it looked like at the first follow-up examination. So we've got a lot of granulation tissue. Now we can see that dysplastic area just at the lower limit of all of these clip artifacts. So that appears to be the adenocarcinoma immediately below where we had closed our target. And again, I'll just skip through some of this video here. What's quite impressive is how nice that surgical closure looks. There's some clip artifacts, but I think you can see this very, very clean closure line right there at 12 o'clock. That those clips produced almost, I don't claim to be a plastic surgeon, but if a plastic surgeon closed that esophagus, it might look a little bit like that very clean scar. On the other hand, we do have those large clip defects probably at the lower limit of the resection. So we did another EMR. We held our breath as we did the snare resection. Unfortunately, it went very smoothly. We took several pieces in the next EMR, and I'll skip that. And the pathology on the second EMR did confirm low and high-grade dysplasia. It did not show adenocarcinoma. We took extensive biopsies of the remainder of the esophagus, and that did not show dysplasia in the remainder biopsy. So we felt like we had resected now the area of concern. And so now another 3 months later, this is actually just a couple of months ago, we brought him back for his radiofrequency ablation. You can see some of the scar here from the EMR with some neosquamous epithelium, and we treated him with a standard 360-degree radiofrequency ablation, and the patient continues to do well. So a difficult situation. I don't know if we did the optimal solution to it, but fortunately the patient recovered and seems to have his primary disease treated now as well.